Dr. Karantanos, thank you so much for joining us here on MD Newsline Podcast. Can you please introduce yourself to our audience?
Thank you very much. My name is Theodoros Karantanos. I am an assistant professor of medical oncology at Johns Hopkins University, Sidney Kimmel Cancer Center in Baltimore. And I'm a laboratory-based physician scientist focusing on the understanding of the role of inflammatory signaling in high-risk myelodysplastic syndrome and acute myeloid leukemia, and the development of novel targeted therapies that can inhibit these pathways.
Mm-hmm. And just to start off, can you please provide us just a brief overview of the central hypothesis behind your study on how inflammatory pathways can contribute to treatment resistance in myeloid neoplasms?
So it has been shown by us and other groups that high-risk myelodysplastic syndrome and acute myeloid leukemia, such as monocytic leukemias and TP53 mutated disease, tend to have upregulation of a number of inflammatory pathways. Those are linked to resistance to a number of agents, including chemotherapy and particularly venetoclax. Our hypothesis focuses mainly on the some interaction between those inflammatory pathways and some growth signaling, but also alteration of the apoptotic priming in the mitochondria that is a key mechanism of cell death related to venetoclax. Obviously, we need further studies, both in vitro and in vivo, to validate these mechanisms.
And what initially drew your research focus towards inflammation-mediated mechanisms rather than purely genetic or epigenetic drivers of resistance?
That's a great question. I initially was interested in sex-related differences in myeloid neoplasms. So men tend to do worse than female. So I was interested in looking into that. And interestingly, androgen receptor, which, as we know, is activated more in males than females, regulates a number of inflammatory chemokine receptors. And one of them, called CCRL2, attracted my attention because it was particularly overexpressed in high-risk MDS and secondary AML, meaning AML arising from MDS. And I studied CCRL2 a little more in the lab. We performed gene editing, knock it down in a number of models, and found that basically this chemokine receptor mainly regulates inflammatory pathways, and that's how I linked my research with inflammatory pathways.
Mm-hmm. And how does this work fit into the broader picture of disease evolution and resistance observed across myeloid malignancies such as MDS or AML?
That's also a great question. We start understanding how inflammatory pathways are linked to disease expansion, evolution, and treatment resistance. It looks like there are two main hypotheses that mutated cells, mutated hematopoietic stem cells, derive some survival advantage in the setting of a very inflammatory microenvironment. So that's one hypothesis, that simply having mutations allows the cells to grow more in the inflammatory microenvironment. The other hypothesis is that this inflammatory signaling is linked to growth, activation of those malignant cells, and acquisition of more mutations can promote further these pathways. I think the truth is somewhere in the middle. There are both mechanisms involved, but I think understanding better how we can modulate inflammatory pathways at different stages of disease progression will be a key to understand better the downstream impact.
Very interesting.